Okay, assalamu alaikum. Acute gastroenteritis. Today's topic, very important, high yield, and very common long case. I'll try to cover as much as I can all knowledge during dehydration part, okay? First, what are the most common organism for AGE? We have them by bacterial, viral, and then the least common are the... wait. Are the parasitic one, right? So first, organisms, the causes, organism. I want to tell you, it's by three. The first one, second one, and third one. So the first one, the most common are viral, okay? What's viral? Rotavirus, norovirus. These are the two most common, adenovirus. But the most common one is rotavirus. We write it in the rotavirus. Okay? Adeno, noro, of course, don't forget them. Norovirus, whatever. And then moving on, bacterial. Bacterial, we have the two S, Shigella, Salmonella, and a very common one, E. coli. So, Shigella, Salmonella, and E. coli. Parasitic one, lastly. Parasite and also fungi, actually. Parasite, fungi. Parasite like what? Cryptococcus. What is it? Amoeba, Giardia, and Cryptosporidism. These parasite, amoeba, and Giardia. The fungi one is Cryptosporidism. Okay. These are the causes of E. coli. I've seen Salmonella case, which caused later Salmonella food poisoning, AGE. Cause later seizures, and from seizures to meningitis. That's why AG is very important to treat from the first stage and to recognize which one is severe, like bacteria, which one is not just viral. Okay? After organism, what are the symptoms? What do we see in AGE? Very clear. The most important one, okay? The typical symptoms, yes, of course, diarrhea and vomiting. These are the most important. Of course, for complication, it has its own symptoms. But what else do we see other than the vomiting, diarrhea? You can see also fever and abdominal pain. But usually they are children; they don't complain of abdominal pain, so we'll skip that one for now. When do we say diarrhea? You don't say diarrhea for someone who had loose stool one time because he was cold at night. So we say it's diarrhea if he had loose stool for 3 days in 24 hours at least. Okay? And when do we say it's loose stool? Not like when it takes the shape of a container. This is the good definition of diarrhea. Okay, who's at risk for dehydration? Some kids are okay, they got diarrhea, but they're self-limited and everything is okay. Infants, because they have low surface area. You know, they're small, but their surface area, they lose. Them losing fluids means a lot of fluids compared to their birth weight. And then the one who passed 6 times of diarrhea in a day, 6 times or more, and vomiting, who had vomiting for more than 3 times in the previously 24 hours. Okay, so what's the pathogenesis? My professor taught me something that, of course, it's fecal oral route, so that food poisoning, you eat it or whatever. Okay, pathogenesis. We have to before, remember it's fecal or root, right? FOR. And before we go into the types, fecal or root or ingestion of contaminated food, poor hygiene, anything like common sense, poverty, environmental hygiene, okay? But the pathogenesis is gonna be divided into two types, okay? Type 1 we call it inflammatory diarrhea, and type 2 non-inflammatory diarrhea. It's quite complicated to understand the difference, but we can say the important part is that inflammatory diarrhea has blood. Non-inflammatory diarrhea is non-bloody. It's more of mucus, it's inflammatory diarrhea, okay? But let's write down this inflammatory diarrhea. Let's try non-inflammatory as the notes says, non first, and then inflammatory diarrhea. Non-inflammatory diarrhea, how does it happen? When there is a watery diarrhea without mucus or blood. This is important point. No mucus or blood. No mucus or blood. Okay? Inflammatory diarrhea, sometimes it has either mucus or blood. Okay? And then sometimes non-inflammatory diarrhea, another important point that there is no fever. No fever. Instead, the inflammatory one, why there is more fever? Because we're suspecting more to be bacterial, and you know bacterial infection is more severe, right? Sometimes. So that's why it's induced fever. Viral, usually low, mild, grade fever. And the non-inflammatory part involves the intestine and does not cause destruction of mucosa. That's why it has no blood. When there is like the virus, it goes invade blah 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 and things, but it does not destroy the lining mucosa of the intestine. So there's no blood. That's it simply. But in inflammatory diarrhea, it causes inflammation, it causes destruction of the lining of the intestine. So furthermore, it causes blood in stool. I want to tell you something. Very pathophysiologic thing, but we have to cover it. When we say, you know that pathogenesis of, let's take rotavirus as an example, because it's the most common, okay? So rotavirus, what's the toxin that rotavirus produce? It's called NSP4, right? NSP4. So when it's produced this toxin, it will lead to activate our immune system will start working, right? So activate cytokines. Cytokines. No, sorry, first part, it does not activate, of course it does activate cytokines, but phospholipase first. It activates phospholipase to talk more P3 about more pathophysiologic things, and then it's IP3. I know you cannot see, never mind, I won't write it down. But this activation of phospholipase, remember your physiology, phospholipase will activate intracellular calcium, and then calcium intracellular will increase. Calcium will be more released, calcium from something ER, the ER part, and then more calcium, and because of more calcium, disrupt the tight junction of cytokines. So you know it's like this, the cell is like this, right? And then there is NSP4 will enter here, NSP4, and then it activate the PE3, and then the P3 will activate the ER, endoreticulum, something I cannot remember, and then calcium release, increased calcium, and this calcium, you know, when there's two junction between the cells like this, right? So this is the junction between the cells. I just wanna forget about this. So the cells are like this, there's tight junction between them. But when you increase the calcium, remember your muscle, it's tight more for contraction, right? But in the small intestine, if you increase it, it will widen. More calcium, increase the tight junction between the cells, and this tight junction, that's it. You'll lose more. You'll lose more fluid. The fluid will still go out easily. But if the junction is tight, no fluid can escape. Wide junction, fluid can escape, just like this spacing. And what we call it paracellular water flow. This is what we have watery diarrhea. This is a simple concept. Okay, how about inflammatory diarrhea? It's direct invading of the bacteria. So this is our lining, intestine, and then the bacteria actually will start directly invading this part. The bacteria everywhere, and this direct invading of the bacteria. You know what cover the immune part of this lining is? Remember Bayer's patches and protein Bayer patches? You remember immunology? So because of this activation, our immune system will start activate the cytokine. The cytokine will activate phagocytosis. Phagocytosis, like this is the immune cell. Phagocyte the bacteria, and then because of this is your lining. Imagine there is a war happening over there, and this is eating the other, the immune cells trying to eat the bacteria. All this will cause destruction to your lining of the small intestine. Because of this destruction, you will have excessive histological damage. The histology of the small intestine will be damaged, and then alter the cell morphology to change this normal cell morphology, and then so alter cell morphology, and now you have destructed small intestine. So it's also same. You will start losing more fluids, more stools. When might be like rotavirus can be actually inflammatory. It's not this is example, not always bacteria, but also inflammatory diarrhea, but might caused by rotavirus when if it affect the microvilli. You know our small intestine has something small like this. I don't know if you even can see it, but if the rotavirus affect this part, and then it will get damaged. So when we wipe it, damage. More space for the fluid loss. Another, again, diarrhea. Okay? Moving from pathogenesis, usually you have to understand the concept, but never mind. Next, risk factors for terrible AGE, not like any usual AGE you get. Of course, patient who is immune suppressed, patient who has underlying, and these things, right? Immune compromised, a child with diabetes, a child with any other condition, and that's the whole story, right? Let's summarize them down. Risk factors. Okay. First, immune compromised. We said it. Close contact. Of course, it's a risk factor. Like, you went to a place they had salmonella in their food. It's not a risk factor. And then malnutrition. Patient who's not have no enough nutrition. No need to explain this word. And he had a very important point: lack of breastfeeding. Why? Because we take our antibodies from the mom. We develop our immune system from the mom. Moms are great. So lack of breastfeeding, your immune compromised, young age. Also, infants are AGE is more risky for them compared to us as adults. So the younger you are, the more dangerous it is. AGE is more severe in children. Why? Yes, this is a question I was like, we have AGE, why it's not as severe as AGE in children? Because they have, because of one thing, it's not AGE itself, because of the dehydration, because of the surface area, dehydration is the part where they really get affected. That's why the treatment of AGE is fluid replacement first. Fluid. This is like dengue, increased plasma leakage. So fluid is that treatment. So because rapid dehydration, inability, they cannot ability, not like us. You tell us, doctor tell us drink more fluid. Okay, that's it. No. Children, inability to tolerate fluid, immature immunity, and high body surface area. Okay. Diarrhea, we have three parts of the diarrhea. Not very important. Acute diarrhea, sudden onset, blah blah blah, dysentery with blood, and persistent diarrhea, which is more than 14 days. Don't come to me and tell me this persistent diarrhea with someone who had diarrhea for 6 days, 3 days, up to 10 days. It's not persistent as long as it's 2 weeks or more. Okay. Assessment of diarrhea. Assessment, we have to, it's not assessment of diarrhea itself, we assess how much the patient lost fluid. So this is a very important part. You want to treat, you have to assess how much you lost fluid, right? Assessment of diarrhea. Okay? One moment. Okay, let's continue. First, we have two types. When you have to know if the patient is I forgot. Wait. Yes. So either he hyponatremic dehydration or hypernatremic dehydration. When does this both occurs? Both patients are losing fluids. How does this happen? So let's clarify this part. First, we have also isotonic. The first part is isotonic. Iso. From its name, iso. We have hypo, and hyper. And you can tell from its name. Please, when you understand these things, it will be easier for you. Isotonic means that the fluid loss, water loss, and sodium loss are the same. So it's isotonic, same exactly. And it's probably not dangerous. Blood sodium stays normal. Water equals salt, looks normal. But hypotonic, from its name, low salt. Hypotonic, low salt, low sodium. Hypertonic, you are questioning now, like you're losing fluids, how you have hypertonic? Because some patients go and drink a lot of water, right? Low concentration, low sodium concentration fluids, like drink a lot of water and then their water increase but the sodium decrease. This is what they're gonna have hypotonic. Okay, so hyponatremic dehydration, when there's a kid of diarrhea, yeah, we've just explained it, and drinks a lot of water, blah blah blah, and then the water moves into the cell but no sodium moves into the cell. This is what happened, and then the vessels become empty. And you know, this shock is even worse than the shock with hypernatremic shock. You suspect hypernatremic shock when the patient has high fever, hot environment, and profuse watery diarrhea. The blood will be increased, concentrated in the blood. The profuse watery diarrhea increase the blood sodium. The water that he's having, the diarrhea, is going into the water is going into the diarrhea. So that will have hypernatremic. Okay, just forget it. That's it simply. You know, the clinical assessment of dehydration, you have to know which is no clinical dehydration, or patient going into shock. Okay, it's going night, so you cannot see now, but you can tell when no clinical dehydration, and then we have clinical dehydration. Yeah, something important you have to treat. or the last part is shock. And the most three important things you have to know, not when you tell the shock, yeah, I know, of course it's important, but later, does he have the hydration or no dehydration? You look for three things: sunken eyes, skin turgor. You know skin turgor when you pinch the baby on his abdomen. Please don't pinch him like adults on his hand. And then sunken eyes, skin turgor, pale. What else? Something. Dry lips. Yeah. These things you have to look when you get a case with AGE. For them so far, they can be tell you if there's a clinical dehydration or not, if you have to be worried or not. So let's say general appearance of patient, no clinical dehydration, he will be okay, urine output okay. You can ask the mom, you can measure the diaper usually. How much are you changing the diaper? As usual, no change of the diaper. Skin color, extremities, eyes, mucous membrane is dry lips. You can check also not the lips, the membrane, the mucous membrane. Okay. In clinical dehydration, it will be dry. There will be sunken eyes. There will be he will be irritable, lethargic, and sometimes deteriorating. If he's in shock, he will be unwell, deteriorating. He will be pale. He will be cold. He will be weak. His capillary fill time is increased. Grossly sunken eye, like you can see clearly, his lips are dry. His mucus is dry. And usually we're not gonna see a patient in shock. We're not gonna put him in the ward, okay? But you have to know, okay? And he'll be, of course, hypertension. Now you wanna investigate. Investigation, what do you do? Of course, there's nothing much, but you do FBC, look for leukocytosis for bacterial infection. You look for stool culture. You can do stool culture, stool FEME. Look for the microorganism. You can do rotaadenovirus test, and look for parasites, oval, cyst bacteria. Of course, you have to do electrolyte, blood plasma electrolyte, and creatinine, glucose, and blood culture if it's required. If you look lethargic. Okay, in history, you have to ask the patient if they had recent travel about their food, what did they eat recently, hygiene, environment, the nature of the stool, as we say. Of course, you can ask about the vomiting, the diarrhea, the fever, the all details things, but I will just mention to you some things that you usually forget. Any prolonged antibiotic, because remember, what was the antibiotic? You tell me later. That gives diarrhea, prolonged antibiotic. And then any thick contact, urine, bowel movement. Does the vomiting interfere with the patient keeping him food? So he's basically loose appetite. He's vomiting everything he eats. Okay? You have to answer this. Duration details, water supply. Of course, any patient, any patient, whether in AGE, any other things, you have to ask about their water supply. Where do they drink water from? Is it filter water or just deep water, something? Because, you know, cholera, very important things. And any untreated medical condition, any illnesses like his vomiting, is it projectile, any blood, any was he giving ORS at home? Did the mom try to treat him at home? Any syrup, any, yes. So far, that's it. Of course, for treatment, I'm tired, we'll cover it later.